That has not joined.
No, sir,
Can't see.
he's not joined it.
Yeah, we will wait for him to join.
Okay, okay, sir.
Let's wait for a few minutes. If you have anything to ask, you can ask.
I think sir has joined.
Yeah, sir has joined.
Today.
Okay, so let me introduce Shaji sir. So, uh, Dr. Shaji K.S., who is presently working as the Dean of the Kerala University of Health Sciences. Previously, he has been working in the Department of Psychiatry at Government Medical College, Thrissur, and he has been working in Thrissur for a long time. Uh, and his special interest is in the area of dementia. And he is also a research guide for many PhD students who is working in who is doing PhD in Kerala University of Health Sciences. And he has worked with a lot of national bodies and local bodies to propagate the mental health as well as dementia. And he was the national chairman of geriatric psychiatry and was the guest editor of the special supplement on dementia. He was also the president of Indian Association of Geriatric Mental Health, and he has received many awards and fellowships. Um, and welcome, sir, and over to you.
Okay, thank you. And Sunil, please let me know whether the audio is okay, volume is
Oh,
okay.
yes, okay, sir.
Yeah, I think. Thank you, Pallium India, for giving me this opportunity. I must start saying this, that 3 days back, I visited the ICMR head Center for Aging and Mental Health at Kolkata. We had a discussion with Dr. Abhik Sinha, and the theme was on how geriatric palliative care has to contribute to home-based care and things like that. So I'm sure all of you will appreciate that palliative care patients, especially people with non-communicable disorders other than malignancy, will need your help, and you are ideally placed to support them and their family members. So I'll begin with saying this. This is my impression. Please correct me. And I'm sure Dr. Sunil will stop me after 30 or 35 minutes so that we can take some questions. I will also try to do that. Most important thing is, even though we are healthcare professionals, we should not presume that we are good in, diagnosing dementia. For example, when I passed MD in 1987, I was not very skilled in diagnosing dementia. When I passed MBBS in 1980, I had no clue about the diagnosis of dementia. So things have changed, and we need to know much more. First thing, even doctors, healthcare professionals, many of them believe that dementia is due to aging or a consequence of aging, which is 100% incorrect. Dementia is a disorder like any other disorder, which is associated with older age groups. You can get dementia earlier, but then generally the risk of dementia increases every 5 years after you turn 65. So that is one thing. Second thing to remember is dementia is a clinical syndrome, which means that by identifying clinical syndrome, you can be fairly certain that that syndrome is present. You do not need any investigation to say that dementia syndrome is present. So the focus of the talk will be on how to clinically identify dementia syndrome. When we say syndrome, like Parkinsonian syndrome, it can be due to various diseases, disease states. And Alzheimer's disease is only one of the diseases or health conditions which cause dementia. So, if these three things are very clear, then it is very easy to comprehend and manage dementia. One, not due to aging, but more common among older people. Two, it's a clinical syndrome which you can identify without any diagnostic test, for example. No laboratory test is required to make a clinical diagnosis. And since it is a syndrome, it's due to various causes. Only one cause is Alzheimer's disease, which is a prototype. Okay, now before I go to the slides, I would want not only you to be very clear about what exactly dementia is, with the understanding and training you have had in medicine, you should now recognize that all of us has intrinsic capacities. Stamina, for example, or the time which you will now require to run 100 meters, that will become less and less when you age. So intrinsic capacities will decline with age. Most intrinsic capacities, not all. So cognitive decline. Dementia is a cognitive disorder. So cognitive decline is associated with aging. That has to be differentiated. That is normal cognitive aging will have to be differentiated, and that will have to be accepted as normal physiological. So how do you do that? Now, it is possible. I'll come to that. Then, what are the cardinal or major criteria to diagnose dementia, the clinical syndrome? First thing is, there has to be a decline in cognitive functions. Second thing, that decline has happened over a few months, and that decline is not considered, cannot be considered as normal. The current level of cognitive functioning of that individual is not normal, meaning when compared to other people of the same age, socio-cultural background, this level of functioning cannot be considered as normal. It is less or it is deficient. Third thing, very important, because of this deficient, dysfunctional cognitive state, you have disabilities in activities of daily living. So decline, a abnormal state of cognition which cannot be considered as normal by any means, which leads to impairment in activities of daily living. This will constitute dementia syndrome. So dementia syndrome, you identify when you get a very reliable history of decline in cognitive functions from a close relative or the person himself. One. Number two, you do simple testing of cognition, memory, and others. Let us designate this cognition as memory plus. It's not only memory, we'll come to that. Thirdly, because of this problem which arises from the brain dysfunction, you have problems in activities of daily living. Okay, let us start seeing the slides one by one. Can I share the slides now?
Yes, sure, doctor.
Yes, sir.
Can you see the slides?
Yes, yes. Can see.
Yeah. We have said many of those things. Dementia is a term which has to be differentiated from normal aging. We said that. And now let me complicate matters little more. See, you have normal aging on one end, then you have dementia, which I described, clinical syndrome on the other end. In between, there is something called mild cognitive impairment. Don't worry about that too much. It's not very clinically important. But remember, if you take people above the age of 65, most of them will have normal cognition. About 10% of them will have mild cognitive impairment, MCI, which is not dementia, but at the same time, it's not also normal aging. It is little more impairment than normal aging. The importance is that 10% of them turn out to be early dementia in a year's time. But it's a very heterogeneous thing, clinically not important. Here, I described the first thing. Second thing is multiple cognitive deficit. See, one of the problems with our general understanding about our brain function is that most of the time, and it is very pronounced and predominant, that memory related functions are very obvious and predominant. But there are other functions like language, executive functions, and things like that. Then to diagnose dementia, you have to have impairment in activities of daily living, which I mentioned. Then exclude delirium or axis 1 disorder, which means that there cannot be something like schizophrenia or delirium. We will not spend too much time on this. It's just that 10% of people above the age of 65 who do not meet criteria for dementia has little more cognitive impairment when you consider their age. We'll not go into this. Ideally, these people might complain of memory problem. It's better to follow them up. These are the numbers. The only number which you need to remember is 5%. If you take prevalence, it's about 5% of older people. That older means 65 or more. And 65 to 70, the prevalence will be about 2.5%. It doubles every 5 years. And by the time you are 80 plus, 30% of 80 plus might have dementia. This is another important thing. It's not from birth. It is something which you acquire. This is again repetition. But then please note that you can have amnesia or memory impairment as the main thing. But then usually, if you look carefully by good history taking and examination, you will also find that aphasia or apraxia is there, agnosia is there, impaired executive functioning. See, if you carefully look at patients, this will be there. If we have time, please Sunil note, we'll discuss about what is executive functioning. Executive functioning briefly is something like this. I knew that there was this Zoom meeting at 6 o'clock. So I started early after work. Then I came. Then I arranged all this laptop so that I could join when I knew that at 6 there will be a call from Sunil. So I had planned and implemented a sequential series of activities and got a task completed. And I'm on that task. That is executive functioning. So that gets impaired in dementia. Aphasia, I'm sure you know. Nominal aphasia is the most important cause. Many names, not names of close relatives, but the names of others. But nominal aphasia is not that. It is inability to name an object which might be there. Uh, uh, we will talk about that later. Apraxia, I'm sure you can look up, many of you will know. This is fairly common among apraxia of gait is very common. Agnosia. I described this. This is about, again, uh, it's about how do you get a history, because if you were to do simple activities like shopping or pay electricity bill or go and get pension from the treasury or go to the bank, all this would require a lot of planning. That agitation, aggression, behavioral symptoms are very common. I'm sure many of you would have seen people with dementia, and I have had people living with me with dementia. So one of her problem was that she was very apathetic. She was not interested in anything when she developed dementia. So that is sometimes a problem. But aggression, agitation, and other behavioral disinhibition could be additional problems. Please do remember, I must, I know that I am addressing a very fairly young group of doctors. Please remember that physical examination cannot be done away with. You must examine all older people, especially older people with dementia, in great detail. So, if you have clinical syndrome of dementia diagnosed, then the next step is very, very simple. You have to rule out reversible causes. So that is something which we might discuss. Here, again, we said it's a clinical diagnosis. Clinical diagnosis includes history taking and examination. So a very important informant here will be a co-resident caregiver, someone who lives in the same household and knows the person mostly. This is about, see, that person will be able to tell you whether they can do all these activities independently or not. See, for example, dressing. It might be difficult or rather slow with dementia. They may need help to brush their teeth, toileting, might have incontinence. They might have problem from getting up to from bed to go to the dining room, things like that. Now, when you say that you have to rule out reversible dementias, remember few rules. Very, very important clinical dictum is that whenever you make a or whenever you identify clinical syndrome, all common causes of reversible dementia has to be ruled out in every case. How do you rule out? By examination or history taking or sometimes investigation. How common is reversible? Suppose you take 100 cases of 100 cases where you diagnose clinical syndrome of dementia. How many of them will have reversible causes? Less than 10, 6, 8, or something like that. But the point is that they are reversible or treatable. And if you diagnose them early, they are much more reversible or treatable. So, hypothyroidism, subdural hematomas, sometimes we have even had temporal meningiomas sitting there and relieved following surgery. Chronic subdural is a very common, eminently treatable condition. B12 deficiency, normal pressure hydrocephalus, drug toxicity. What drugs are toxic, or which are the drugs which cause cognitive impairment? To put it simply, all drugs with anticholinergic effects can impair your cognition, starting with trihexyphenidyl, procyclidine, antihistamines, even drugs like deriphyllin, digoxin, Lasix, furosemide, all of them will have little bit of anticholinergic activity. So if somebody is on more drugs with anticholinergic activity, the cumulative anticholinergic effect might make a condition which is similar to that of dementia. Of course, hepatic causes and other causes, metabolic causes are there. Infections, HIV is an important cause. Other disorders, of course, if you identify, we have had people with that syphilis improving with treatment. We said this. Electrolytes important. I would think VDRL and TSH are important. We hardly see any VDRL positive these days. B12 levels, whenever there is a question of poor nutritional intake or more vegetarian, then you will have to really look into this. CT can by and large rule out, but then if there is no issue with money, payment, then an MRI would give you much more details regarding vascular lesions. Because many small infarctions, especially subcortical ischemic lesions, will be missed on CT. Okay, so reversible is good. Now, when reversible causes are ruled out, then you have two major sets of causes. One is that vascular dementia. Second one is neurodegenerative. How do you, before saying that, please remember about 40% of patients will have vascular dementia and about 40 will have neurodegenerative dementias. Rest will be others. So how do you recognize whether someone has a new... See, please note that I'm not using the term Alzheimer's disease here. I'm using a term called neurodegenerative dementias to refer to Alzheimer's disease, frontotemporal dementias, dementia with Lewy bodies, and other neurodegenerative dementias. So, just a recap of what we did. First, you establish that there is progressive dementia syndrome, more than a month or few months. Reversible causes are ruled out. Then you rule out vascular dementia. How do you do that? History of cerebrovascular disease or event. Evidence on imaging that there is cerebrovascular lesions. That is how you rule out. Now, before we get into neurodegenerative dementias, please remember that there are broadly two types of vascular dementia. One is that you can have a major infarct. For example, you can have a stroke, one or two strokes, cortical infarcts. But then what is being more recognized now is that you have someone with long-standing diabetes or hypertension, then has multiple subcortical ischemic vascular episodes, and then you have lots of subcortical areas not functioning and thus presenting with dementia. So, if you can rule out reversible dementias, then vascular dementia, then you are either dealing with dementia with Alzheimer's disease, dementia with Lewy bodies, or frontotemporal dementia. These are the most common among neurodegenerative dementias. It may not be important for you, but then it is good to know, because otherwise every neurodegenerative dementia will be presumed as Alzheimer's. There are slight differences in prognosis and in management. For example, dementia with Lewy bodies should never be given antipsychotics. Frontotemporal dementias may not be helped by drugs like cholinesterase inhibitors and things like that. But I fully agree with, meaning any specialist will agree that it's very tough. If the person has severe dementia, you can't really make out whether it is vascular versus neurodegenerative or whatever. So if you have ruled out reversible causes, then vascular dementia, then you have to rule out. This is what I think is feasible and ideal. Rule out dementia with Lewy bodies. How do you do that? If there are visual hallucinations, very well formed. We recall that once when we saw a patient with dementia with Lewy bodies, she was talking about, see, look, there are that small children there, give them some food. She was seeing, nobody else could see. So, when there are visual hallucinations in a person with dementia, then you suspect that this person has dementia with Lewy bodies. Then history of falls, many episodes of falls. Then any past history of unpleasant or catastrophic reaction to anti-psychotic drugs like risperidone or any other drug. Then you suspect. The good news is that they might respond to cholinesterase inhibitors. So this is the criteria. And again, fluctuating cognition. Sometimes they appear as if they are confused. Some for few days, then they become better. Recurrent visual hallucinations. And I forgot to say that spontaneous Parkinsonism. Now, important to note this, Parkinsonism can happen in people with dementia, even in people with Alzheimer's disease. But that happens very late into the illness. To complicate matters further, a person with Parkinson's disease with no dementia can go on to develop dementia later on as part of the course of his Parkinson's disease later on, which will be very evident by history and examination. So you have to make that distinction. But then if you see someone with dementia and rigidity, not so much tremor, cogwheeling, and then slowness of movement, then with visual hallucinations, you must suspect dementia with Lewy bodies. Never ever give antipsychotics or dopamine blocking drugs to them, even when behavioral symptoms are there. So avoiding neuroleptics in patients with spontaneous Parkinsonism, visual hallucinations suspected to be having dementia with Lewy bodies is important. Consider cholinesterase inhibitor drugs like donepezil, etc. Then false prevention would become important. Frontotemporal rather has an earlier onset, maybe before 65. Here, the hallmark of the illness is that you lose insight very early. You deny problems. You don't think that you have any abnormality. And they can have all sort of behavioral symptoms. Personality change. Totally different person, disinhibited. They usually happens to people below the age of 65. They're physically very strong and they are hyperactive, wanting to move around. So it can be a problem. So again, they may not respond well with, meaning antipsychotics will have to be avoided, and probably you will have to give much more support. But these are very rare. So in the order of frequency, you have Alzheimer's disease as the predominant group. So if you take 100 neurodegenerative dementias, about 70 will be Alzheimer's, maybe 15 will be dementia with Lewy bodies, 5 plus will be frontotemporal. In frontotemporal cholinesterase, there is no evidence for benefit with cholinesterase inhibitors. Now, just revisiting vascular dementia, we briefly did neurodegenerative dementia. Vascular dementia is common, extremely common, fairly common in India and Asian countries because multi-infarct. I said you can have a stroke here. So one cortex, wedge-shaped cortex is dysfunctional here, somewhere here. So that is another one type, one territory gone. Stroke, hemiplegia followed by dementia. But what is interesting is that we are picking up much more cases of subcortical ischemic vascular dementia. You have some history of giddiness once in a while, some vascular episode, but then nothing like a hemiplegia or hemiparesis. But then you see multiple subcortical ischemic vascular changes. How do you manage? Vascular dementia is by adopting vascular risk reduction method strategies. Sometimes when depression is there, it might help. How do you manage Alzheimer's disease? Before that, you have to look at executive functions. Behavioral symptoms are fairly common. So that is how you do that. I'll maybe that slide thing, we have slides for some other thing. Maybe I'll stop here and I must talk about management after this. Is that okay, Sunil? I'll take a break here so that diagnosis part is covered. Is that okay with you, Sunil?
Yeah.
So I'll stop sharing here now. You could ask me about diagnosis, identification of cases. So that is something which will be interested in. Are there any questions or?
Any questions? So, sir talked about various types of dementias for the things which can come under dementia and how to diagnose each. So, there is a question regarding how to distinguish between apathy and depression.
Oh, yes. Can I answer that question? Yes, that's a very good question. Apathy, first of all, it's not easy to understand apathy. I'll give you one example. I referred to someone at home. See, if I am having dementia, how do you decide whether I have apathy? See, all of us are connected to the world around us. So I may be reading newspapers, I'm interested in knowing the news, I'm bothered about what happens in the place of work or in the neighborhood, or I talk to people. We have interests which is beyond where you sit or lie down. So there is this outer world to which we are connected. When you become demented, your capacity to be part of rest of the world becomes less. The person whom I was referring to, she wouldn't know. She's not interested to know what is happening outside. Finally, as the empathy became very progressive, she was concerned about what happens in her room, not even in the rest of the house. So, people, it is not, it's actually due to a deficiency of a capacity to comprehend the environment and make sense out of it. So, how do you differentiate that from depression? Depression will have sadness of mood and report of sadness of mood, or if the person is not capable of reporting sadness of mood, you can obviously feel that that person looks sad, unhappy, and is tearful. And that is very different from see, empathy is more like something like lack of expression or reduction in the range of expression. Of course, I understand that empathy can be part of depression in late life, but then the core of empathy is that you are less responsive to the environment. Whereas depressed mood is that you have subjective suffering due to mood. Yes, what are common early warning signs of dementia that oh yes. See, I'm 66. So you are asking me that question. That's interesting. See, if a person has difficulty in recalling instances which has happened in, say, 48 hours or 24 hours prior to testing, that is, when you examine, he or she is not able to report what has happened in the last 24 hours. That is when you establish that there is a problem. Then, how do you get history? See, for example, I'll give you this is a personal example. My mother once called me and said that her first cousin is no more, and I should. She said that she was intimating me, and if possible, you should attend the funeral. She said. So I had some exam duty that day, so I could not go. A day later, she called me and asked me, "Don't you know that so and so is no more? Did anyone tell you? Did you know?" She asked. See, she was the person who called all of us and broke the news, which means that she had recent memory impairment. So that is when we started suspecting dementia. Another example would be if you tell, as you go out of the house, you tell somebody, older person in your house that, say, when so and so comes, tell him that we should get one more packet of milk for today. So that is passing a message. If that person who was capable of doing that earlier is now incapable or inconsistent in doing that, that is when you suspect dementia. When someone has a problem with dressing, though putting on a shirt or wearing a sari will look very simple, there are mistakes like which can be due to apraxia, not apraxia. It is due to difficult dressing apraxia. You cannot put the right button, the right buttonhole, and things like that, or has difficulty in grooming, uh, doing complex tasks like going with a list of things to buy and then not able to carry out entire shopping. So these are the early signs usually. And inability to get names. That's much more common actually. Misplacing things and searching. Sometimes they misplace things and then they accuse others of having kept it taken away or stolen or even misplacing it deliberately. So these are the things which you should make suspect. And another thing is executive functioning. See, executive, all of us, our work is mostly based on our ability to use our executive brain. We make decisions, we implement decisions. So implementing a decision based on a plan is something which many people cannot do after they develop, meaning when they are in the early stages of dementia. And if you have executive dysfunction, you cannot be participant for a group activity. For example, if I were to help someone taking this table from this room to another table, it's a group activity, 2 people or 3 people trying to do that. When I do that, if I have dementia, I will not be able to guess what that person is going to do. And I will not be able to modulate my, participation based on what the other participant is doing. So inability to take part in group activity which demands cognitive abilities is another age, another early sign. Yes. Any other question? And another important thing, Sunil, is that all right? If I important differential diagnosis is that sometimes with this knowledge, you might misdiagnose delirium as dementia, especially in palliative care settings. That should not happen. So, can I spend 5 minutes on that delirium? No slides, just that much. Is that okay?
Yeah. It's okay, sir.
Delirium versus dementia. I'll say first dementia. Dementia usually is a gradual onset, slowly progressive, sometimes due to degenerative causes, sometimes due to vascular causes. So, gradual onset, slowly progressive dysfunction is something like chronic renal failure, chronic cardiac failure, congestive cardiac failure, or heart failure. It is actually brain failure, chronic brain failure. Whereas delirium is acute brain failure, where the brain suddenly becomes dysfunctional. Now, coming to delirium, delirium happens just like that. So acute. I'm normal now. After the class, I wind up at 6 o'clock. By 8 o'clock, I'm totally abnormal in my cognitive and behavioral state. Then there cannot be any other diagnosis but delirium. So it could be due to hyponatremia, but then hypoglycemia, encephalitis, cerebrovascular disease, anything of that sort, acute encephalitis. So delirium is acute, dementia is gradual and progressive. Delirium is acute, either the person recovers or the person will die. Delirium is florid. Somebody was asking, one of you, what are the early signs? There are no early signs of delirium. You have it florid. You have a person who cannot have good attention or concentration. His awareness, his or her awareness about the environment is totally abnormal. He cannot comprehend what is happening. For example, if somebody in a ward has delirium, he will not know for sure what exactly is happening in the ward, why others are there, why people are there. He does not know. Uh, he is not able to comprehend the environment. Secondly, the most important disturbance in delirium is in consciousness, level of awareness. You are not oriented to time. You are not oriented to place. And of course, you may not be able to identify people around. So, disorientation and poor attention and concentration is the hallmark. Whereas delirium, these things are rare and happens very late and happens when there is superimposed dementia. So delusions and hallucinations may be there. Like in dementia with Lewy bodies, you have you can also have visual hallucinations in delirium. But then remember, they are more at night, more when light is less, and disturbance of sleep-wake cycle will be very dramatic. They won't be sleeping at night. Motor agitation will be there. Sometimes there will be hypoactive delirium, like hyponatremia, liver disease, chronic liver failure, and things like that. So delirium is something which you must learn. Yes. So any more questions? If you want me to talk about antipsychotic drugs, you can ask me.
Please ask anything if you want.
There was one question. There was this elderly patient with mild cognitive decline, FAC, and history of multiple falls with most likely diagnosed. Very good question. Actually, the usual three things are there. One is visual hallucination, but that's not an essential requirement. The other essential requirements are one, fluctuation in sensorium, that is fluctuating course, early Parkinsonism, and delusions or hallucinations. So, if there is cognitive impairment which will meet criteria for dementia, FAC is not common in dementia with Lewy bodies. Falls can happen in vascular dementia also. So, history, if there is no Parkinsonism, no visual hallucinations, no history of fluctuation in the level of symptoms, then it may not be like, look carefully for Parkinsonism. May not be. And duration is also important. Usually, the cognitive deficiency will not be much. It could be with history of multiple falls, it could be vascular or dementia with Lewy bodies. So you get a CT or an MRI to rule out vascular. Then if the duration is short, please do consider dementia with Lewy bodies. Possible. And avoid antipsychotic drugs. Very good question. This is usually asked. Can loss of a close relative like spouse, can it precipitate dementia? This is something which people tend to believe. There are reasons why it might appear like that. See, when the more so following the death of the spouse, the answer is that bereavement does not cause dementia. But then, how do you suddenly recognize that the person who is older person undergoing bereavement has dementia? You know why? Most of the time, the other person, spouse, husband or wife, he will be so supportive. And because of the assistance received from the spouse, many a symptom of dementia will not be apparent to others in the family, even in others in the family. So that is it. When a person with mild dementia loses the spousal caregiver, her symptoms will become manifest much more. This has happened to us. But then we knew that my mother always, we knew that she had dementia. But my father died first, and then she became much more, we realized that she had so many deficits because that was being looked after by my father who stayed in the same room with her. Yes, that's a good question. Loss of job, nothing will precipitate. It is stress will not precipitate dementia. I'm sure about that. Stress might precipitate uncontrolled vascular, or if you are under stress and if you are not using proper treat, or you are not compliant with good treatment for diabetes and hypertension which you have, then downstream consequences like stroke or myocardial disease or something can lead to dementia. But beyond that, no. Is there any other question which?
Sir, could I just ask about significance of family history? And is there anything to prevent, delay dementia? There are children who are very concerned once their parents get diagnosed.
Yeah. Thank you, Priya, for asking that. It's very important. In a jovial manner, I must say that I have family history of dementia. My mother had dementia. So it's like this. It depends on whether it does not depend on family history of dementia. It depends on family history of a type of dementia. For example, if my mother probably had Alzheimer's disease, she had late onset Alzheimer's disease. So Alzheimer's disease has family history, or there is a genetic component, which is only one risk factor, a predominant risk factor. It does not mean that all relatives will have dementia, but then having family history of Alzheimer's disease in first degree relative increases your risk for development of dementia in late life. So I'll send Dr. Sunil an infographic which talks about prevention of dementia. About a third of causes, more than 30-40% of factors which can lead to dementia or which increases your risk of having dementia can be modified. That's all about it. So I can't modify my genetic risk, but I can modify many other risk factors. Because like hypertension, it is the cumulative risk which decides the onset of dementia in your life. So if you have higher risk, uncontrolled risk for longer periods of time, you have an earlier onset. Now coming back to Alzheimer's disease, late onset dementias are not that genetic. No, these are based on available literature, whereas early onset Alzheimer's disease may be more genetic. But frontotemporal dementias are much more genetic than Alzheimer's disease. So generally you see people, one or two siblings with frontotemporal dementia in a family. If that is the case, again, the risk will be high. About worries about developing dementia, I don't think anybody should worry. You need to worry only as much as you worry about having cardiac illness like coronary artery disease. All those risk factors are common. So you delay coronary artery disease by reducing vascular risk factors. Then if you wear a hearing aid, if you have long-standing hearing problem, if you can stop smoking, if you are physically active, and if your brain has had exercise during its development, meaning good education, if you have exercised your brain during your job, employment, and if you continue to use your brain into late life by exercising it, by being cognitively active and socially active, you can delay the onset of Alzheimer's disease.
Sir, is it possible when there are multiple episodes of hypoglycemia, is it possible for such a patient who is diabetic to have dementia?
One second. Very good question. The answer is any number of the number of hypoglycemic episodes, or for that matter, any event which has an insult to your brain will put you at a higher risk for later dementia. It could be hypoglycemia, recurrent episodes of delirium, hypoxic or otherwise, repeated brain trauma, or repeated infections, central nervous system, which is curable. All that will put you at a higher risk for dementia, meaning you might develop dementia earlier than, say, for example, if you have never had hypoglycemic episodes, especially the level of glucose and the amount of insult, which it is not measurable immediately. See, suppose I have hypoglycemia, how many neurons will die? I will not know, because it will not get manifest. But then prolonged hypoglycemia will cause neuronal death, or let me put it this way. Dementia manifests when you run out of or when your cholinergic reserve becomes less and less. All of us uses cholinergic function to do our cognitive or execute our cognitive abilities. So you need intact cholinergic neurons to be without dementia. So any insult like hypoglycemia, delirium due to any cause, which will invariably cause death of few neurons, will actually reduce cholinergic reserve.
Thank you, sir. So one more question. Is there any medicine, any drugs that we can take or give to a person who has started developing dementia to, restrict the further worsening?
That I should have covered that in detail, but then of course this is a brief. All of you, I'll pass that detail to Sunil. There is a drug, my choice. There are number of drugs called cholinesterase inhibitors. I will prescribe donepezil, which comes as 5 and 10 milligram. Use 5 milligram tablet. What it does is to work on the cholinergic hypothesis of dementia. But then remember that it is not cure. it will only help. The current evidence suggests that in selected cases of Alzheimer's disease and dementia with Lewy bodies, if you have mild to moderate dementia only during that period, some people respond favorably. Not that dementia will get reversed, it will become less intense and the decline will become slow slope than otherwise. We have had patients who had benefited from taking donepezil daily in the morning. It does not have major side effects except it can cause arrhythmias in people with slow pulse and bradyarrhythmias. Initially, some of them might have gastric side effects like nausea, vomiting. Otherwise, it is a well-tolerated drug. If I were to get dementia, I might take donepezil if it gets diagnosed early for some time and if I am tolerating it well. So, cholinesterase inhibitors, especially donepezil, is the drug of choice for people who has Alzheimer's disease or dementia with Lewy bodies, but definitely benefit will be in the mild to moderate stage only. And if the person goes on to severe, profound dementia, there's no point in continuing this. I will definitely stop that. And if you start this has to be monitored daily, not daily, sorry, monthly.
Mhm.
And look for history of falls, syncopal attacks, see that pulse is regular, no GI side effects. And then see after 3 or 4 months whether at least qualitative improvement is there reported by the relatives. Then you continue.
Mhm.
Otherwise, if there is no change, people find it difficult to afford, then stop. It costs about 10 rupees or 12 rupees per day. Thank you for asking that.
Thank you, sir.
Sunil, I will send you, I'll request you to send you some material which you might want to send to all participants, like
Okay.
the NIMHANS guide and things like that. So I'll do that in the next 1 week.
Sir, can you speak something about the caregiver burden in dementia?
Sunil, can you repeat that?
Also, I was asking that can you speak on caregiver burden in dementia?
Okay. Oh, yes. Thank you. I think I'll send you that material also. Okay. Somebody asked about drugs. Let us say that drugs are not the mainstay. Fully agreed. How do you treat dementia? Management is very simple. Sunil had highlighted that. That is, you start first, you identify that somebody has dementia, then you identify that person. Then you should start identifying people who are looking after that person, who are care providers or care partners or caregivers. Identify them. Most often in Indian setting, there'll be one person who is assigned to this duty or happens to do most of the work and take almost all the responsibility. That person is ideally designated as the primary caregiver. So after the diagnosis of dementia, then after identification of primary caregiver, you must recognize that there is burden due to disease. And dementia is one condition which has tremendous burden of care, which is associated with burden of care. Burden of care in three simple terms: it is emotional, it is labor, and it is finance. So people spend a lot of money. Many people will have to resign their jobs, cut back on their work, which means that there is loss of income. And there is a lot of emotional cause because behavioral symptoms and impairment in things, activities of daily living like incontinence and sleep disturbance, all that uh, will have negative impact on the caregiver. So what you do is you assess caregiver burden, but then your aim is not to measure caregiver burden. Your aim is to identify the caregiver and offer three things. One, inform and educate about dementia. What symptoms are there and how much of that is due to dementia? Because misinterpretation of genuine symptoms of dementia as deliberate misbehavior is very common among literate relatives also. So, one, inform and educate. Two, support. Support means emotional and other support. Third is guidance. Guidance for management of symptoms. This guide which I propose to send uh, will have many, there are many guides. You Google Alzheimer's Disease International, Alzheimer's Association, you get caregiver guides. These guides will have information on for the caregiver, which says that how do you handle, say, wandering? How do you handle sleep disturbance? How do you handle incontinence? Do you handle repeated questioning? So this ideally we can actually help you. Sunil, we are making an offer here that if someone wants to prepare a guideline, a caregiver guide in their language, we will be able to help them. Because in Kerala, we have designed a 16-page booklet, 1/8 size, which we invariably give to the caregiver, read, come back, and then you start discussing with the caregiver. So the post-diagnostic follow-up, which is the most important part in management of dementia, comprises of a partnership between the caregiver and the care provider. Care provider is you. Care partner is the one who provides care for the person with dementia. So you work through various times, and that is how you go about doing it. Sunil, that is over to you.
Okay. So,
Yes.
question regarding late onset dementia, is it necessary to evaluate the patient for reversible process of dementia?
Answer is yes. Every time you diagnose dementia, see, which are the things you evaluate? One is routine tests. TSH has to be done in every case. And if there is history of vascular event, get an MRI done if they can afford, or a CT done, or do a neurological examination to say that there are no focal neurological deficit. Then B12 deficiency, sometimes you may not get that test everywhere. Then generally clinical evaluation will be enough. Checklist, check all the medication for anticholinergic drugs. And that's enough. Consider that every time.
Sir, can you tell us something regarding behavioral and psychological symptoms of dementia and how to manage those?
Yeah. These are the most difficult to manage symptoms of dementia. Behavioral symptoms, for example, socially inappropriate behavior, wandering. These are difficult to manage. So anything which is unusual and socially inappropriate is a behavioral symptom. Psychological symptom, again, this is the terminology used to designate things like delusion, hallucination. Symptoms which are seen in psychiatric illness without dementia are symptoms which can also be seen in people with dementia. So, management wise, it will be nice. Are we under pressure for time? How much time we have? I am okay.
We have 20 minutes.
Oh, really? Very good. So I'll explain that. Delusion, by definition, is a false, unshakable belief, not shared by others. In dementia, there are two common delusions, meaning two common abnormal beliefs which people express. One is people are stealing things. We had a mother-in-law of a college lecturer accusing the daughter-in-law of stealing her soap, bathing soap, because she misplaced it. And she said somebody has taken it, must be daughter-in-law. Stealing things like something is missing. So stealing things they can't find, they accuse others. Second one is, this is not my home. The person believes when he or she is in their own home that it is not their residence. So these are symptoms which you should not treat with antipsychotics because these are due to deficits. Whereas sometimes there can be paranoid delusions associated with lot of agitation, screaming, and things like that. Sleep disturbance. Then you may have to use antipsychotics if you cannot find out that, or you, after assessment, think that it is not situational. We have seen patients with delusion of infidelity, thinking that husband or wife is having some affair, and that one delusion alone, sometimes you will have to treat that. Another behavioral symptom which is very common is sleep-wake cycle disturbance. They will be awake at night and sometimes during day they'll be asleep. So that is basically a circadian rhythm disturbance which is difficult to manage. Other than that, difficult symptoms are repeated questioning. They will ask same questions again. So for everything, there is a, what shall I say? You can, the principle of handling an abnormal symptom of dementia is that you have normal brain. That is, all the relatives, caregivers, their brain functions normally. Whereas the person with dementia has a dysfunctional brain. So sometimes the normal functioning brains can use certain strategies to cope better with the person with dementia. So, for example, if somebody says that this is not my home, I want to leave, I want to go to my house. One strategy which might help is that, okay, we'll go, but not now. After some time, and then you distract, anyway, come, let us see TV for some time. So maybe for half an hour, 1 hour, person will not. So distract and redirect attention sometimes can reduce or help in managing certain behavioral symptoms. That's one thing. Another thing is, again, this is important. Say, for example, there is no point in using, suppose you want, of course, this is not about behavioral symptom as such. You see, a hypothetical situation, daughter-in-law or daughter is a bank employee. This is something which has happened. So she wants to give breakfast to the mother-in-law morning, and then she wants to leave for the bank. So she is telling mother-in-law or mother, whoever it is, that please have breakfast. So mother-in-law is not in a good mood. So she says, no, I don't want breakfast. So she says, why don't you have? Then she gets little more impatient. No, I have to go to the bank. Don't you know that bank starts at 9 o'clock? Don't you know that I was late yesterday, and today also if I am late, then I'll get problem. See, this will not work. The person with dementia has a dysfunctional brain. Her ability to comprehend spoken language is diminished. She will only recognize, and rightly, that daughter-in-law is angry with me. So she said, if you are angry, you get angry. I don't care. So instead of saying that once or twice, you can say, then you leave it at that point of time. Don't pick up a quarrel. No point in showing, no point in communicating with too many sentences and words. Telegraphic language, repeat once or twice. After that, if it does not work, stop. Then avoiding making people physically active during daytime and preventing them to lie down might help to improve sleep. Cutting down on caffeine and stimulants after 4 p.m. especially will help to improve sleep. Symptoms like incontinence might be helped by regularly prompting them at intervals to pass urine. Avoiding very frequent changes in the environment will help them to reduce restlessness and agitation. Same room, same home. See, if you stay, the person stays with one son for 1 month, then goes to another son. We have had a situation where dementia care every 3 months will change houses. That's not good. So it is. There are so many ways of doing this, but then you will have to discuss with the caregiver about possible strategies. Another one thing which people try is to have bolts and things like that, which is not easy to open, so that a person who has tendency to wander away will not know how to get out of the compound and things like that. Anyway, it's not easy.
Any more questions?
Looking for, this is something which I recommend strongly. Whenever there is a change in behavioral symptoms, sudden exacerbation, then you should consider a superimposed delirium. It could be an infection which precipitates. See, older people above the age of 65 has a higher propensity to develop delirium. older people with dementia is at a very, very high risk for development of delirium. So if I have dementia, if I have mild hyponatremia, I'll have delirium. If I have a chest infection, I will have delirium. So people with dementia, when there is a sudden exacerbation of behavioral symptoms, rule out delirium by checking metabolic parameters, looking for infection, and sometimes it could be even a impacted fecal matter and distress and pain associated with it. That's all.
Okay. Sir, I think we can wind up for today. So please send me the document. I will remind you regarding that. So thank you, sir, for taking this much time from your busy schedule and speaking to us on a very important topic on dementia and clearing many doubts. Thank you very much.
Thank you, Cyril, for this opportunity. I look forward to answering you. I'll send you the details. Thank you very
Okay,
much.
sir.
Thank you all.
Thank you, Shaji sir, for the wonderful session. Thank you, Sun sir, for facilitating the session. Thank you, everyone, for joining. Thank you. Let's see you in the next session. Bye.